Dr. J here, Dr. Jenkins. These are going to be a couple short videos just to drive home some points that are actually quite important, but we just don't have enough time to cover them in class. So for those who are interested, these are just going to be some quick little videos to talk about them. Not be on a test in class, but this first one, I just want to talk a little bit more about that calcium that we said was so important for cardiac muscle contraction. And I want to relate it to what's happening in the ventricles during ventricular systole when they contract, right? So I know there's a lot of information on here, but I'm going to try and summarize it relatively easily. I'll try. What different color can I use here? I guess I'll use blue. I don't know. So the top left here, this is what we already talked about. This is what, when we put electrodes on someone's chest and then the upper and lower limb leads, this is what the readout looks like. I made a point of saying that this is not a direct electrical recording of what's happening in the heart. It's indirect. However, that's fine because we still have a lot of, we know how that indirect measurement should look, and we can still identify a lot of things that are going wrong by what it looks like from the machine. But I wanted to just mention what's actually happening. And we're going to focus on the ventricles because that's what's going to be ultimately pumping blood to the lungs and out to the heart. So what we see here is a representation of what's actually happening electrically in the ventricles. This is not as easy to do, right? You actually got to shove electrodes in the myocardium while it's contracting. So it's way harder to do, but I think it's illustrative, okay? So I want to point out a couple things. We can notice here that the specialized tissue helping to spread the nerve impulse even through the ventricles is autorhythmic. So in terms of the ventricles, we know we have that path of the nerve impulse traveling down the interventricular septum via the bundle branches. It gets to the bottom or apex of the heart, and then the nerve impulse travels up the side walls of the ventricles through the Purkinje fibers. These are still part of that small amount of autorhythmic tissue. And as such, they don't have a stable resting membrane potential. Instead, the resting membrane fluctuates. Usually it fluctuates somewhere between negative 85 to negative 100 millivolts. Just wanted to point that out. It's possible for us to divide what's actually happening electrically in the ventricles into these 4 phases. And I've superimposed what the EKG is doing. So I put it in dotted lines. And of course, because we're talking about the ventricles, which part of the EKG corresponds with ventricular depolarization would be the QRS complex. So you can see, we can see the R, the S. So we can see kind of it superimposed, just to give you an idea. But I just want to focus on 0. Phase 0 here is in this way called the upstroke. Sodium channels open to positive 30. Gee, that sounds kind of similar. Phase 1, we get up here and we have, now that we've brought in enough sodium, we can initially depolarize. Some sodium channels will close, but we also will begin to open some potassium channels. Not all that different, but here is what's different. Phase 2. And it's called a plateau. So we can see there's an extended period of time here where, because of the influx of calcium, we're able to maintain that depolarization. In other words, maintain the contraction. Didn't we say that myocardial muscle can stay contracted longer? It's because of calcium, and this plateau stays contracted for longer. If you're interested, during this phase 2, there's an equal exchange of potassium and sodium, but the important thing is the influx of calcium. And then we will repolarize at the beginning, and then we'll get back to the resting charge. But the electrical activity looks a little bit different in real life.